So today we are doing an encore presentation of the Palliative Performance Scale from our Tools in Your Toolbox series in 2020. But we're putting a bit of a spin on it. We're going to do a bit of a recap with the recording, as well as some live chats with our guests today, Sue and Kathleen. But before we get started, I would like to go through our land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of the Chippewa of Beausoleil, Rama, and Georgina Island First Nations, and most recently, the Mississauga of Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And we all know we are here for the Palliative Care Echo Project. The Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare providers across Canada who care for patients with life-limiting illnesses. For more information, you can go to echopalliative.com. And we would like to send a special thank you out to Health Canada for their financial contributions. Production of this presentation has been made possible through the financial contributions from Health Canada. The views expressed here today do not necessarily represent those of Health Canada. And for some of you, you may recognize our faces. For those of you who are new, my name is Amanda Tavelda. I am the Communications, Fundraising, and Community Relations Specialist with Hospice Aurelia. And our co-hosts today are Kathleen Bartlett and Sue Martin. Both are palliative pain and symptom management consultants with the North Simcoe Muskoka Hospice Palliative Care Network. Welcome, Kathleen and Sue. It's so great to see you today.
Thanks, Amanda. Welcome, everyone.
So, as I mentioned, we are actually going to be doing a bit of a recap. We'll be playing a short clip, a video of our recording from 2020. And it is still very relevant. You'll actually see Sue in the video, and one of our colleagues who's now retired is also in the video. And then at the end, Kathleen and Sue will go through some case studies with everyone. So enjoy the video, and I'll be back at the end.
So our plan today is to provide some education on the Palliative Performance Scale, and then we'll have a number of case studies to review, during which we really welcome your comments. And we ask that you use the chat box if you have any comments or questions throughout the presentation. And between Charlene and Amanda and I will be monitoring all those comments coming in. Here are the learning objectives for today. So by the end of the session, participants will be able to explain what a palliative approach to care means, define and discuss the Palliative Performance Scale, describe the benefits of using the Palliative Performance Scale, and implement the Palliative Performance Scale. And sometimes we will refer to the Palliative Performance Scale as the PPS. It's much easier to say. So the World Health Organization's definition of palliative care is that it's an approach that improves the quality of life of patients and their families facing the problems associated with a life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So what does that mean? Well, it's the way that we provide care for people who have a life-limiting illness. A palliative approach to care focuses on providing good quality of life through great symptom management, and the patient and family are always at the center of care. It's best if it's initiated early. It's not limited to end of life. It can be provided at any point along the disease trajectory, and it aims to improve or maintain quality of life. It's a holistic type of care: physical, psychological, spiritual, social. It's appropriate for cancer and non-cancer diagnoses and for people of all ages. It works in conjunction with treatment, not in place of treatment. And prevention is really important. We try to anticipate problems due to the illness and not react at the last minute. A palliative approach to care is best provided by a multidisciplinary team in any setting: in hospital, retirement, long-term care, community, group homes, wherever that person chooses to be. So this picture has been adapted from the Model to Guide Hospice Palliative Care, and it shows the relationship of palliative care and restorative care, or therapy to modify disease. It demonstrates how offering both types of care concurrently can create a really robust model of care for the patients. And that offers them really good quality of life and symptom management alongside other therapies. Anyone with a life-limiting illness would benefit from a palliative approach to care. It can begin at any point along the trajectory, as I mentioned. It can begin at the point of diagnosis, or perhaps at the point of admission into a long-term care home. It includes care which provides comfort measures along with active treatment, such as dialysis or blood transfusions, chemo, radiation, and these types of treatments will change as time progresses and the patient's goals of care change. Palliative approach includes end-of-life phase and bereavement phase. So remember the surprise question. If you answered no to that surprise question, it's time to initiate a palliative approach. So these are some of the tools that we use in palliative care. There's quite a few here, and there's many more, but the tools that are highlighted in red are the tools that are included in this ECHO series. Here is the actual tool, the Victoria Hospice Palliative Performance Scale version 2. So this is what we are teaching. Sometimes we call it the palliative performance story because it actually tells the person's story. A little bit of background for you. The Palliative Performance Scale, or PPS, was developed by Dr. Downing and the Victoria Hospice Society. The PPS is a significant modification of the Karnofsky Performance Scale. It was introduced by Dr. Downing in 1996 as a new tool for measurement of performance status in palliative care. And the article by Anderson, Downing, Hill, and Casorso was titled Palliative Performance Scale, a New Tool, in February 1996 in the Journal of Palliative Care. In 2001, revisions were made resulting in the Palliative Performance Scale version 2. And there are over 200 research studies on PPS in areas of language translation, prognostication, clinical value, surveillance, and many others. So the PPS, it's a reliable, gold standard, validated tool. It's used for assessing a patient's functional performance. It's been translated into as many as 17 languages. There are 11 categories, which are measured in 10% decrements, and it's divided into 3 phases. The stable phase is 70 to 100%. The transitional stage is 40 to 60%, and the end of life stage or phase is 0 to 30%. So what are the benefits of using PPS? Well, PPS can be used for many reasons. First, it's an excellent communication tool for quickly describing a patient's current functional level. It provides interprofessional team communication and is a great communication tool across all healthcare sectors. Consider for a moment if you're working in a long-term care home and expecting a transfer of a patient from an acute setting. If there's a PPS associated with that person, it can give you a huge amount of information. PPS is a framework for measuring progressive decline over the course of the illness. And with residents and families, it can be used as a visual teaching tool to indicate change in status. It can be a guide to help in initiating and facilitating conversations about a palliative approach to care or those end-of-life care transition conversations. And it can help family members in making tough end-of-life decisions. It also appears to have a prognostic value. The rate of change in PPS can be an indicator of life remaining. For example, changes over periods of months may mean that that person has months left to live. Changes over periods of weeks may mean that that person has weeks left to live. Or changes over periods of days may mean that that person has days left to live. It may have value also in establishing criteria for workload assessment or other measurements and comparisons. Many of our guiding documents refer to the development of collaborative care planning, and the PPS guides the selection of appropriate palliative collaborative care plans. So Charlene is going to talk about the key points for training.
Hi, so as Sue said, I'm going to just review some of the key points for training when we're using the Palliative Performance Scale. Leftward parameters outweigh rightward parameters. We always try to find the best fit horizontally. Clinical judgment of the best fit horizontal fit should override any ambiguities. Definitions are important. We always need to keep in mind that it's not what the patient is observed doing, but what the patient is capable and able to do. PPS is simple, but not always easy to use. We really need to find the best fit scenario. So I'm going to further review the 5 different categories in the PPS: ambulation, activity and evidence of disease, self-care, intake, and conscious level. So with ambulation, full ambulation, a person has no restrictions and does not need any assistance with ambulation. Reduced is the degree to which the patient can walk and transfer, and occasional assistance may be required. It's often at the level of a PPS of 70 to 60%. And then by using the adjacent column, the reduction of ambulation is tied to the inability to carry out their normal job, work occupation, or some hobbies and housework activities. The person is still able to walk and transfer on their own, but a PPS of 60%, they might need occasional assistance. Mainly sit, lie versus mainly in bed, the PPS at this time is 40 to 50%. Subtle differences between these two reflect the amount of time that the patient is able to sit up or needs to lie down. A general rule is if the person requires assistance with care and transfers and can only sit up for short periods, they are considered mainly in bed. A PPS of 30% or less, person is unable to get out of bed or unable to do their own self-care. Totally bedbound is due to either profound weakness or paralysis, such that the patient not only can't get out of bed, but is also unable to do any self-care. And of course, a PPS of 0 is death. So when we talk about activity evidence of disease, activity is based on a person's normal activity linked to daily routines and hobbies, job or work. This work might be paid or unpaid. A decline in activity may mean that the person still plays golf, but has to reduce that from 18 holes to 9 holes, or may resort to backyard putting. People who enjoy walking might find that they just can't go as far and have to go a shorter distance. Evidence of disease is broken down into no evidence. So this is the individual who's active as they normally are prior to becoming sick. Some significant and extensive disease refer to physical and investigative evidence showing degrees of progression. For example, someone with a cancer diagnosis, a local reoccurrence would imply some disease. 1 or 2 mets in the lung or bone would imply significant disease, whereas multiple mets in the lung, bone, liver, brain, hypercalcemia, or other major complications would be extensive disease. The extent may also refer to the progression of disease despite active treatments. The extent of disease is also judged in the context with the ability to maintain one's work and hobbies and activities compared to their normal or usual degree of activity. So moving on to self-care. So full self-care indicates total independence. So PPS at this time is 100 to 70%. At 60%, this is often occasional assistance is needed. Patients are able to transfer out of their bed, eat by their own means, but may need a little bit of assistance, maybe once a day or a few times a week. At 50%, considerable assistance means that regularly every day, the patient needs help, usually by one person, to do most of their activities. For example, the person may need help to the bathroom, but then is able to brush his or her own teeth and wash their hands and face. Food might have to be cut up into edible sized pieces, but usually at this time, the person can still feed themselves. At 40%, mainly assistance. So it's a further extension of considerable. Using the same example I just gave, person needs help getting up, but now often needs assistance with washing, brushing teeth, shaving. They still can usually eat with minimal assistance at this time though. And this often does fluctuate according to their fatigue level during the day. Total care means that the person is completely unable to eat without help, toilet, or do any self-care. Depending on the clinical situation, the patient may or may not be able to chew or swallow food once prepared for them. So intake. Changes in intake are quite obvious. With normal intake is the person's usual eating habits well healthy. Reduced means any reduction from that is highly variable according to the unique individual circumstances. Minimal refers to very small amounts, usually puree or liquid, which are well below nutritional requirements. And mouth care only, at this time, there's no oral intake at all. So conscious level. Fully conscious implies full alertness and orientation with full cognitive abilities for that person. Fuller confusion, the level of consciousness may be full or it may be reduced. The confusion might be related to a delirium or dementia, which could be mild, moderate, or severe, and it could have multiple possible etiologies. Fuller drowsy plus or minus confusion, the level of consciousness may be full or markedly reduced. Sleepiness may be due to fatigue, drug side effects, delirium, or closeness to death. Sometimes a patient may be in a stupor at this time. Drowsy or coma plus or minus confusion, a person has no response to physical stimuli. Reflexes may or may not be present, and the deep coma may fluctuate throughout a 24-hour period. At this time, death is usually imminent.
How to use the PPS. PPS scores are determined by reading horizontally at each level to find a best fit for the patient, which is then assigned as the PPS score. The leftward columns are stronger determinants. Begin at the left column and read downward until the appropriate ambulation level is reached. So read down the ambulation level when you determine what the appropriate number is, then read across into the next column and downward again until the appropriate activity or evidence of disease level is located. And these steps are repeated again across all 5 columns, and then that will give you the appropriate PPS. A few things that we don't do: we don't add up the scores, and we don't break it into pieces based on different categories. We follow 10% decrements, choosing a half-fit value of PPS, such as 65 or 75, is not correct. It would have to be 60 or 70. So who should use the PPS? What are your thoughts around the PPS? Any healthcare provider can actually provide and use the PPS. The accuracy of PPS is based on understanding the definition of the words and how to apply them, how it's calculated, not based on the discipline or the role of the person using it. So any healthcare provider can use the PPS. A physician, a PSW, a pastoral care, social worker, anyone can use it as long as they understand how to use it. Family and patients at times benefit from using it as a visual to help explain changes and rationale for discussions at certain times. So when should the PPS be completed? In the community setting, when the patient's status is not stable, the PPS needs to be done at every visit. In the hospital, the PPS should be done daily. And in the long-term care setting, the PPS should really be done on admission. The Quality Long-Term Care Alliance supports the use of PPS, and many long-term care homes actually have it in their policies to complete the PPS on admission and quarterly along with the MDS-RI. But regardless of the setting, the PPS should be completed when changes are noted in the patient's status. PPS guides appropriate selection of the palliative collaborative care plans, such as I was just going to note that the Ontario Palliative Care Competency Framework really references the use of collaborative care plans. So all of our guiding documents suggest the use of these collaborative care plans. And PPS is a great tool to guide that. So now we have some conversation around the different phases. We have the stable phase, the PPS of 100 to 70%. So Charlene, can you tell me how that person might present?
So this person is likely independent at 100%, but at 70%, they may be using a cane and they may need to be reducing their work hours. A PPS approaches 70%, there's significant disease evident upon investigation. At this time, the appetite is often starting to decline as well.
Thank you. Hope changes as the patient's disease progresses. So during the stable phase, it is an opportunity to start discussions and conversations about the patient's understanding of their disease and its management. This can lead into discussions about goals of care and advanced care discussions. This can also allow us opportunity to discuss the support team that's available, such as home and community care, maybe a palliative care physician is needed, or physio, and many others that can be available to support as changes are occurring. Now the transitional stage is 60 to 40%. How would this person present, Charlene?
Hi, this person will likely have a further reduction in ambulation. At this time, they might be using a walker or unable to participate in any hobbies or housework. Loss of independence is apparent in this phase. This is when a person may need alternate care arrangements, such as a retirement home or long-term care home, depending on the supports that are available to them where they live.
Great, thank you. So what considerations should we take into account at this transitional stage or phase? It really is a difficult time. They all are, but most difficult this phase for patients because it impacts on all spheres of life. So it really reinforces that need for a holistic patient and family-centered care. At this phase, the patient usually requires increasing amounts of nursing care. So consider the psychological, the social, and the financial changes. This is when we would most likely be introduced to those patients requiring more care. Increasing educational needs of the family and the patient and the care team are noted, and case conferencing is really helpful. Advanced care planning discussions and essential conversations about patients' wishes, beliefs, and what their goals for care include are really important considerations to include. So these steps will help to guide the development of a plan of care to manage the patient's disease progression. Now, end of life phase, that's PPS of 30% or less. Charlene, how would this person present?
So at this time, the person is bedbound, requiring total care, and will have a progressive decline in their oral intake. We see a declining level of consciousness, and the patient at this time may have some confusion, and they may be actually slipping into a coma as death approaches.
Right. So what considerations should we keep in mind in the development of a collaborative care plan at this point? Well, effective communication, again, is necessary to facilitate those end-of-life discussions that are related to the cultural and the spiritual values, the beliefs and practices at end of life, the emotions and the fears, exploration around past experiences with death and loss are really important, and clarifying those goals of care, and also the family preference related to direct care involvement. Some families are hands-on, and some prefer not to be quite so hands-on. Other considerations would be educating and sharing information with individuals and their families about the reconciliation of medications to meet the individual's needs. Consider, are there strategies in place to support the medication needs, such as a symptom relief kit? Is there an alternate route of the medication, perhaps a sub-Q route? Reviewing potential symptoms is really important. Physical signs of impending death, discussing the vigil practices, the self-care strategies, identification of a contact plan for family when death has occurred is really important. Is there an Edith protocol, an expected death in the home protocol, if the person is hoping to have a home death? And what care of the body after death would be appropriate according to that person and family's beliefs? As previously mentioned, there are over 200 article reviews related to the PPS, and we found two of particular interest that we'd like to share with you. So Charlene's going to talk to you a little bit about this first study.
Okay, so the first article that we're referencing here is a very current article from 2020, taken from the journal called Palliative Medicine. The article itself was entitled "The Palliative Performance Scale Predicts Mortality in Hospital Patients with COVID-19." So very relevant in the world that we're living in right now. The aim of this study was to evaluate whether pre-admission PPS scores would be a predictor of outcomes. It's a US-based study, and it was just in one public hospital in the New Jersey area. The study group contained 374 eligible participants over the age of 19 admitted to hospital with a diagnosis of COVID-19. Overall, the mortality rate of this group was 31%, but the mortality rate increased to 81% in those that had been intubated. In all, 36% or 134 of the patients had a low PPS score compared to a high score. Patients with a low score were more likely to die and more likely to have a do not intubate order and to be discharged to another facility for care. So the conclusion from this article is that pre-admission PPS independently predicts mortality in patients hospitalized with COVID-19. The improved predictors of mortality can help the clinicians caring for patients with COVID-19 to discuss prognosis and provide appropriate palliative care, including decisions about life-sustaining therapy. So this was just kind of a very brief overview, but I did find this article very good and quite relevant, and I'd really encourage you to take a further look at this article.
Thank you, Char.
And now Sue is going to talk about.
So this abstract was found in the Journal of Pain and Symptom Management, published in 2011. I thought it was interesting because although it's a very small study, its objective was to determine if they could use the PPS as a screening tool to see if a patient would benefit from a palliative consultation. So the title is Who Needs Palliative Care? Using the Palliative Performance Scale to screen for palliative consultations. It was written by Dr. F. Zaire and Dr. W. Jackson from the Methodist Alliance Hospice in Memphis, Tennessee. The aim, as I said, was to assess the viability of the PPS version 2 as a screening tool for patients who would potentially benefit from a palliative care consultation. They recognize that palliative care services are beneficial to patients, but in their healthcare system, it was often utilized very late in the hospital stay, usually on day 7. So there was a 30-day pilot study, and it was completed using the PPS version 2 to assess a selected sample of patients from a med-surg ward. Inclusion criteria were an acute medical admission, a hospital stay of greater than 48 hours, and an age of 65 years or older. Patients were considered to be appropriate for a palliative care referral if their score was 40% or less. So 26 patients were screened. The median age was 78. 96% were African American, 63% female, and the median length of stay was 6 days. 11 of the 26, so 42%, had a PPS of 40% or less, but only 1 received a palliative consult. Interestingly, qualitative surveys were done which revealed that the staff members found that the PPS was very easy to use. It was helpful in identifying patient needs, and it was unobtrusive to their routine workflow. So that's good. And in conclusion, on this med-surg floor, many patients missed the opportunity to benefit from a timely referral to palliative care. 42% screened and 99% actually received the referral. So the PPS version 2 may be a practical screening tool for select patients in identifying those who might benefit from a palliative consultation. I think that this is a really interesting idea. Not everyone requires an actual palliative consultation, but imagine if patients were screened with the surprise question and the PPS. It would surely trigger an early palliative approach to care and cue healthcare providers to start having those essential conversations.
So we're going to go over a couple of case studies. There's 6 in total. We are going to do a poll, so we ask that everybody participate. It will be a little white screen that pops up, and it has all those 10% increments. If you can select which one you feel fits the best and hit the submit button, that'd be great. So case study 1 is Lucy. She's a 58-year-old female. She was diagnosed with breast cancer after a lump was found through a routine mammogram. She had a lumpectomy and radiation was completed. She took 2 weeks off of her work. She currently is on oral medications, tamoxifen. She works at Honda doing shift work. She sleeps well most nights. She has a good appetite. She still has some lingering tenderness and swelling at the site. So what do you guys think that her PPS scoring would be? So if you can just select one of those numbers and hit submit, Amanda will close the poll once it's all done. Making sure you're kind of going through those 5 different categories of their ambulation, excuse me, activity, evidence of disease, their self-care, intake, and conscious level. So majority rules, 44% of you say it's 90%. That is the correct answer. Again, going across that scoring tool, it seems we don't have full information, but Lucy is still working at Honda, so she's ambulatory. It doesn't say that she's using any mobility aids at that time. She is taking oral medications, but it doesn't look like she has anything else that's inhibiting her mobility and any other evidence of disease noted. She is able to care for herself. It doesn't say that she's requiring any PSW support or assistance from family and self-care. Her appetite is still good, and she is still conscious and with it enough to continue her work. So good job. We'll go to the next case study. So case study 2 is George. He's an 88-year-old retired male. He's diagnosed with metastatic prostate cancer with mets to his bone. He lives in a retirement home. He walks to the dining room for 3 meals a day, but he often forgets his walker, which we see that often. He enjoys snacks and visiting with other residents each afternoon. Some short-term memory loss. He does require assistance with showering, more so with his back and feet twice a week. So what do you feel that this gentleman's PPS scoring would be? So we'll do the same thing. The poll will open, choose your best bet. 60%, perfect. So 50% of you say it is 60. So his ambulation is a little impeded. He's using a walker, which he tends to forget. So that kind of brings him down to that reduced mobility. He is requiring some assistance from staff for his ADLs. His appetite still remains good, so that kind of puts him in that transitional / stable phase, and he is suffering some short-term memory loss, so that will bump him back down again, so 60%. Okay, so case study 3 is Marion. She is an 86-year-old female who lives in long-term care. She was diagnosed with advanced congestive heart failure and COPD. She's on oxygen at 3 liters per minute. She enjoys sitting in her comfy chair at the window to watch the birds. She uses a rollator walker to walk from the bathroom to her chair. She does become quite exhausted with any activity and requires time to catch her breath. Sometimes the oxygen is increased for that short period of time in order to get back to her baseline. She is very independent, but does require assistance with personal care due to her increased fatigue. She often spends the entire afternoon resting in bed. She does usually have tea and toast at breakfast, no lunch, and only 50% of her dinner in her room. So what do you feel that her PPS would be? So majority of you said 40. This is kind of a harder one. Sue and I discussed this one too, as well as the next case study. For her ambulation, she's mostly sitting in her chair. She is getting up a little bit, so we would kind of put her down in that 40 to 50% range. She is requiring some assistance with her personal care, so that's bumping her down. Again, she requires considerable assistance, so that's kind of like that 50% range. Her appetite is her normal. It's not a significant decrease to what she was used to before, and she is still cognitive. So that's why we put her at the 50%.
Okay, so this is John. John's a 74-year-old male in long-term care. He has a diagnosis of metastatic head and neck cancer. He experienced a marked increase in weakness over the past week. He spends most of the time in bed. He is transferred to a wheelchair by 2 staff each evening to visit his son outside. 2 weeks ago, John was able to sit for 20 minutes, but now he can only tolerate sitting for about 10 minutes. This is based on a true situation. John is dependent for personal care. He is alert and capable of directing his own care. John had a G-tube inserted many months ago and continues to receive full feeds during the night. His oral intake is limited to sips of water, and he enjoys sips of coffee. The disease continues to progress, and John has had some bleeding from his mouth a few times each day, and he enjoys watching TV and listening to music. So given this information, what do you think his PPS might be? This one's a little tricky as well. So most of you said 30%, and 29% of you said 40%. Okay. So again, this is a little tricky, but Kathleen and I discussed this as well, and we came up with 30%, based on the fact that he's totally bedbound except for that 10 minutes in a full 24-hour period. And evidence of disease progression, he's had increased weakness and bleeding from his mouth. He's total care, dependent for personal care. His intake is normal for him with the G-tube, but it is reducing. And his level of consciousness is, he's alert and he's directing his own care. So we would put him at a 30%. And remember, it's a best fit scenario. A few weeks before, I would have put him at a 40% if he was able to sit outside and visit with his son for a while. But at 10%, he's pretty limited. So we can't do a 35. So we put him at a 30. Okay, next one is Agnes. She's a 91-year-old female diagnosed with advanced dementia, colon cancer, diabetes, congestive heart failure, osteoarthritis. This lady has been in long-term care for many years. Although she does not recognize her family much of the time, she does enjoy company. She loves music. Agnes wears a brief as she's incontinent of urine and stool. Each afternoon, her daughter helps her to get up and brings her down the hall to the dining room for lunch in a wheelchair. She usually sleeps in the afternoon. Agnes is taken to the dining room at dinner, but can only remain up for 1 hour, and staff provide all personal care. So what do you think her PPS might be? So this is a tie. 33% said 30%, and 33% said 50%, and 17% felt that her PPS was 40. So we felt that she had a PPS of 50% because she's mainly sitting and lying for the day. She's getting up into her wheelchair, but she's also lying down for a large part of the time. So that would put her at a 50%. And we do start at the left-hand column, and that is the strongest indicator. So that would put her at 50%. And then her evidence of disease, she certainly has incontinence of urine and stool, no recognition of family, and she's mainly assist with personal care, but she can feed herself. She's dependent for her personal care. So we put her at a 50%. Okay, so now Agnes is unable to tolerate sitting up in her wheelchair. She spends all day and night in bed. Some days staff report blood clots in her brief, and she's eating small amounts of soft food, but she must be fed. So at this point, do we have a poll for this one or not, Amanda? Yeah, okay. What would you say her PPS would be at this point? 30%. Yeah, 58% of you said 30%. 33% of you said her PPS is 20, and 8% said her PPS is 10. So without doing more polls for this slide, I think we'll just go through the next scenario here. Is Agnes is now taking sips of fluids only. Sometimes her breathing is irregular and even stops for a few seconds. So at this point, we know that her ambulation remains the same. She's bedbound. And then we also know that evidence of disease and activity, her evidence of disease is continuing. Previously, she was eating small amounts of soft food, but she had to be fed. And now she's only taking sips of fluid. So if you look at your PPS and look over to the intake column, you could see the difference between 30% and 20% is the fact that the person is at 30% eating solids, normal or reduced, and at 20% is minimal or sips. So that's the difference. She would be at a 20% PPS. And then the final scenario where Agnes is not taking anything by mouth, she's sleeping most of the time. Her feet and legs have become mottled, so there is disease progression. She's totally bedbound, and she's dependent for all care, but her intake is what's different. Again, she's not taking anything by mouth at all. She's requiring mouth care, and so her PPS at this point would be 10%. So that's the difference in the 3 stages, 30, 20, and 10. Any questions on that? Our final case study is Peter. He's a 46-year-old male. He's a paraplegic from an accident at the age of 10. He has recently been diagnosed with stage 3 non-small cell lung cancer and will be undergoing chemo and possibly radiation treatments. Peter was previously independent with his transfers and personal care, but is now finding that he fatigues more easily and requires assistance getting back to bed at the end of the day. Peter's appetite remains good. So now, using your PPS scale, where would you put this person? So most of you, 40% of you, felt that Peter's PPS was 70. But there's quite a variation. 10% thought it was 90, 10% thought it was 80, 20% thought it was 60, and 10% thought that the PPS was 40, and then 10% thought it was 30. So let's go through this. Peter, so his normal level of ambulation, even though he's in a wheelchair, that is normal for him. So looking at the ambulation column, which is most heavily weighted, he is requiring some assistance with his transfers, whereas previously he was totally independent. So that does put him at a 70% reduced level. Okay, looking at the next column, activity and evidence of disease. Well, he is fatigued, so that does tell us that his there are some changes. And then self-care, he remains independent in his personal care, and his intake, it looks like his intake is normal, and he's quite capable of making his own choices. His conscious level is full. So that would indicate to us that his PPS is 70%. And so it's important to remember with the PPS that we look at what the person's normal is and what they are capable of doing, not what we as staff members think that they should be doing. What is the difference between 20 and 10%? Okay, good question. So at 20%, a person is totally bedbound. They have extensive disease. They require full care. And the difference at 20% is that they're taking minimal sips of fluids. Compared to 10%, a person is totally bedbound, extensive disease, require total care. And the difference is that they're only having mouth care. They're not able to take any sips. So that's the difference. And the conscious level column, they can be full, drowsy, or confused at either 20% or 10%. So it's really the intake that determines the difference at 30, 20, and 10.
So thank you guys so much for joining us today. If anybody does have any questions, please shout them out here. Amanda has included a couple of links over in the chat box. So one is to our virtual resource binder. You can download a copy of that. It has a whole bunch of education series, resources. And then she has also included the link for our ESAS that will be presented in February. And then if you guys don't mind, one other thing, if you wouldn't mind taking a survey just to give us some feedback on how we can maybe improve the sessions, what you might like to see in future sessions, that would be great.
And I see there's a question about the video. Yes, we will be sending out a copy of the recording. Thank you, Tracy. That's a great question. Excuse me. And I've lost my voice. We will also send out copies of all of the appropriate tool links as well. So you'll get a copy of a accessible version of this, as well as the slides, and you will get a copy of the PPS as well. And don't forget to sign up for all of our other ECHO sessions. We love having everyone here. And thank you so much, Kathleen and Sue. This was fantastic. And it's always great to hear current case studies gone through with the PPS. It's always interesting to see, you know, there's such flexibility in each person's thinking. So to actually apply this, it's really great. So thank you so very much for being here and for providing that for us today.
Thank you so much.
Have a great day, everyone.